Thank you. Thank you for organizing committee for I have an opportunity to talk this meeting. I'm Chul Lee from Seoul, Korea. The adjacent segment pathology is a major complication of lumbar fusion surgery, and minimally invasive surgery has the advantages of preserving posterior muscle and ligamentous structures. However, whether this minimally invasive approach decreases the incidence of ASP than open conventional surgery remains unknown. The purpose of this study was to determine the incidence and risk factors of adjacent segment pathology requiring surgery and compare survivorship according to the fusion method, minimally invasive TLIF and open conventional PLIF. This is a retrospective study of 740 consecutive patients, minimum 1 year follow-up. The 564 patients were treated Open-PLIF with open conventional pedicle screw instrumentation, and 176 patients treated by minimally invasive TLIF and percutaneous pedicle screw instrumentation. The ASP requiring surgery was defined as a symptomatic condition in which additional operation was required to treat the pain and neurological deterioration at adjacent segment. We reviewed the protocols and the medical records, any presence of revision surgery at adjacent segment, and we checked the follow-up period, time of censoring, it means a lost follow or time of ASP. We also examined various risk factors, age, sex, BMI, smoking status, diagnosis, fusion method, number of fusion segments, and presence of adjacent level decompression. We use a survival analysis. This is the green color, each tick remarks represent time of one patient was censored, is lost follow-up. Also, the red incidence is ASP requiring surgery. It represents drop in the survival curve. We use a survival analysis with a life table method and Kaplan-Meier curve reconstruction. For risk factor analysis, a Cox proportional hazard model was used. Both groups are quite similar in demographic profiles in terms of age of surgery, sex, BMI, diabetes, or smoking percentage. Also, type of pathology. However, the follow-up period is slightly longer in the Open-PLIF patients, so we included these factors in the multivariate analysis. It adjusted by statistical calculation. The incidence of ASP requiring surgery, 26 patients had undergone surgery for adjacent segment pathology. In the Open-PLIF group, 3.9% of patients. In minimally invasive TLIF group, 4 patients at 2.3%. This is a live table. You can see at 10 years, the ASP occurred 13% of patients. The annual incidence was about 1.4% per year. And Kaplan-Meier survival curve shows that at 10 years, the 87% of patients disease-free at adjacent segment. This means the incidence of ASP in 10 years about 12%. We compare the two fusion methods with the Kaplan-Meier survivorship curve. We found that minimally invasive TLIF significantly less incidence of ASP during the follow-up. And also, age more than 65 years has more chance of ASP than younger than 65 years. However, BMI and diabetes was not a significant risk factors. In a multivariate analysis, Cox regression method shows that the age is more than 65 years increased risk about 2.9 times. And also the fusion method, Open-PLIF, increased risk about 3 times. In summary, after posterior lumbar interbody fusion surgery, the Kaplan-Meier analysis predicted 12% have additional surgery for ASP within 10 years, minimally invasive TLIF results in fewer ASP requiring surgery than Open-PLIF in survival analysis. Also, patients aged more than 65 years are 2.59 times more likely to undergo revision operation than younger patients. Thank you for kind attention.
Thank you for a great study and actually good results, rather low rates of adjacent segment disease overall if you look at your long-term results. There's one question from the floor that I would like also to follow up and include in one question. The question here was, why did you compare Open-PLIF and not Open-TLIF versus MI-TLIF? And maybe you can comment a little bit on how your Open-PLIF procedure was done. Maybe I missed it. Is it a laminectomy or is it just a bilateral? If you do the Open-PLIF, do you do a laminectomy or do you cut the posterior tension band or do you come from both sides? And maybe you can comment on why not doing Open-TLIF as a comparator.
Yeah, it is some kind of philosophy. When we open, I think putting two cages are better than just one cages. But I understand that one cage or two cage biomechanically different. But in most of studies, one cage or two cage did not result in a significant difference in ASP. So I think that is not a great concern. And I understand that we have to examine that kind of with the same kind of the operation for conventional and minimally invasive. That's a good suggestion. Thank you very much.
But in your Open-PLIF, you did a laminectomy, a midline approach.
Midline laminectomy.
Okay. And then another question is on potential selection bias. How did you choose what the patients did get? So why did one patient get an Open-PLIF while the other one may have gotten the MIS technique?
Yeah, great question. It is not a prospective randomized study, so there may be some difference in selection, but we try to minimize and we exclude the revision surgeries, or also our practice gradually from open to minimally invasive surgery. So ideally, the prospective comparison is best, but in a real world, it is very difficult to do. This is a very need a long-term follow-up, and the incidence of ASP less than 5%. So we have to use a retrospective analysis, a large number of patients with a survival analysis. So I think try to minimize the indication or two surgical methods and some bias. So we try to minimize it by the multivariate analysis using Cox regression.
Okay. Okay, there's a question, well, that's difficult. How would you explain that BMI did not affect adjacent segment disease? But maybe I can also reform that question. So what do you think is the difference? Is it just the muscles? And because you didn't talk at all about lordosis, something that nowadays everybody here talks about, that if you re-establish lordosis, your ASD rate will be lower. And then people argue maybe this depends on the surgical technique. So did you look at lordosis in your study?
Actually, we did not include our radiographic result, and two groups are identical in terms of lumbar lordosis and PI and PI-LR mismatch. So it is not so much different according to the fusion method and radiological parameters. But I do believe that we preserve posterior muscle and ligament structure when you do the tubular lithotractome minimally invasive surgery connecting to adjacent segment. That's why the incidence of adjacent segment was lower in minimally invasive surgery group.